Not hear you.
Yeah. Thanks again.
Okay, thank you very much. Thank you all for coming. I'm Stephanie Stevenson. I'm the Executive Director of the BC Pediatric Society. First of all, I want to really thank Stellar Jeans Greer for being our sponsor tonight. Really appreciate your support of this what's going to be very interesting, especially when I get the right valuation form. So Kelly Liu, Dr. Kelly Liu is the newest member of the BC Pediatric Society Board, and she is going to introduce Tiffany Wong. Thanks, Kelly.
Thanks. So I'm happy to be able to introduce Tiffany today. Welcome. So a friend and colleague of mine, and she's a clinical assistant professor at UBC and with the Department of Pediatrics, and also works as a clinical allergist and immunologist here at BC Children's Hospital. I think some of the work she does is pretty cool, and I think it's a reflection of how much she cares about kind of improving the quality of life for kids with allergy, allergic diseases, and also creating positive relationships with other healthcare providers. So she's a trained pharmacist, and so interested in drug allergy, and one of her projects is to identify tools to be able to delabel penicillin allergies so that children have more medication selection and improved quality of care. And then, of course, her other interest is immunotherapy, which we're going to talk about more tonight. When Tiffany was asked to do this talk tonight, she kind of reached out to her pediatric colleagues and asked for suggestions. And I said to Tiffany, I would really love to know about what the naturopaths are doing, because this is what, the questions I get in my office. So I'm delighted that the focus of her talk today is immunotherapy, evidence-based versus alternative practices, and I'm sure we're all going to learn something that we can take home with us. Great. So join me in welcoming Dr. Tiffany Wong.
Thank you for the kind introduction. So anytime in medicine we have the ability to change the natural history of a disease, I think it's really exciting. And so immunotherapy to me is a really special part of allergy, and it's really near and dear to my heart because I was telling Jane Finley that I had it done myself when I was younger, and so it has a lot of personal importance for me. So full disclosures, I'm an advisory board member for Airless Pharmaceuticals. I've done some speaking engagements for Pfizer, Stellar Jeans Greer in the past, and Novartis. I meant to tell you that I've had full editorial control over all of my slides tonight. And so anything wrong on the slides is my fault. So the objectives I think were previously circulated. It's really hard to talk about immunotherapy without a little bit of background, so I will start with some brief pathophysiology, and then we'll discuss some of the current available immunotherapy specifically for pediatrics. At the end, we'll talk about some of the therapies that are offered by alternative healthcare providers and perhaps what to do when a patient comes to you having already seen a naturopath or alternative provider. So physiology slide, all allergic diseases basically start the same when it comes to IgE-mediated allergy. So in this case, we have a respiratory epithelium, but really all allergic processes start at interfaces between outside of the body and inside. So it could be really the skin, the respiratory mucosa in the nose or the lungs or even in the GI tract. In the case of allergic rhinitis, which is the focus of today's presentation, is the respiratory epithelium. So what happens? Can you see my mouse? No mouse. Okay. So in the top left, there's an allergen, and what happens is particles come through the epithelium and they're engulfed by dendritic cells, which are essentially the surveillance cells. And the dendritic cells will chew them all up, process them, and present them on MHC molecules. They'll bring them to the lymph nodes and present them to T cells. And if the T cells recognize any of the allergens they're presenting, they become activated through inflammatory mediators, and they tell the B cells to produce specific IgE antibodies. The IgE antibodies float around in the bloodstream and come to sit on mast cells that are resting in the tissues at the surfaces of the body. And so the next time you have contact with the allergen, there's mast cell activation, degranulation, and it pours out all of its mediators. So the the immediate mediators include histamine, leukotrienes, prostaglandins, and then you have later mediators that are produced, and those mediate what we call the late phase reaction. So these lead to symptoms of chronic congestion. They cause things like not able to smell properly, and those are really more chronic symptoms. And so if you have constant exposure to an allergen, you have constant acute phase reactions and late phase, and that leads to this ongoing process, which is really difficult to stop once it gets started. So it is a quality of life issue, but it does have a big impact because it affects over 20% of the global population. And so there are studies indicating globally that at 6 to 7 years of age, there's an 8.5% prevalence of allergic rhinitis, which almost doubles by the time you're an early adolescent. Impacts your quality of life. People who have significant allergic rhinitis and conjunctivitis can't sleep well, and these children don't do well in the daytime, so they're really tired. I had a patient today that was falling asleep in class every other day at 11 years of age, which is not good. And then there's this increase in primary care visits. Parents have to take time off work to take their children out of school and take them to the physician. There are a lot of guidelines available. So the main ones that we use are the ARIA guidelines and guidelines from the American Academy of Allergy, Asthma, and Immunology. And I'm not going to go through all those today. So allergic rhinitis really is the tail end of the atopic march. And most of you will know that atopy is really a collection of diseases. And the first thing you usually see is atopic dermatitis early in infancy, followed by food allergy and then asthma. And then allergic rhinitis is really the last condition to appear, although you can have appearances of these diseases at different parts of early childhood. So indoor allergens lead to year-round symptoms, which makes sense, right? Because they're always there and you're always in your house. So the critter on the top left is a dust mite, and it's actually the enzymes in the poop that they excrete that you're allergic to. So they aerosolize, and you breathe them in while you sleep because they feed off of our skin cells. So anywhere our skin cells are, the dust mites are. And we spend majority of our time indoors in our beds. So they are concentrated in our pillows and our mattresses, and also anything that's upholstered, so couches, carpets, etc., and has nothing to do with cleanliness. Cats and dogs and other pets as well. And then molds is a question I get from time to time. So there are a lot of indoor molds. Most of them don't matter. And so I've just sort of put them on the side there. Before we go any further, I'm still seeing, well, actually, I don't think this will ever go away, but we have families that come and they have dogs, but it's okay because it's hypoallergenic, but they swear that they're allergic to everyone else's dog. So this was a fun study actually from 2012, and what they did was they took a variety of hypoallergenic breeds. So on the far left there, that's a Labradoodle, and the control dog is the Labrador Retriever. Then we have a Poodle, a Spanish Water Dog, and an Airedale Terrier. Now all of the other dogs other than the control, they don't shed, and that's why they're marketed as hypoallergenic dogs. So what they did was they collected samples of the hair, and then they vacuumed the animals themselves, and then they vacuumed the floor of the homes they were in, and then they took random air samples. And they were looking for CAN-F1, which is the major dog allergen that we are allergic to. And if you look at this rather busy chart here, you can see that the line for CAN-F1 levels, the average line for the Labrador Retriever, is actually significantly lower than the other dogs. So they are definitely not less allergenic. They all carry the same allergens. And so some people would say, well, that's fine, but then that means there's less dog allergen in my environment, and therefore I'm not having as many symptoms. But when they looked at the environmental samples, they were actually no different. So that is a myth we've worked hard to debunk, but I think that marketing has beat us there. So we don't encourage it. I think that it's possible that you can become tolerant to your own pet and still react to other dogs, and that is less well explained. It's probably related to different CAN-F proteins, but we don't have the ability to sort those ones out with our testing. So we're left with just having to recommend avoidance. Okay, so seasonal allergens. The most important ones here in British Columbia are tree and grass pollens. The blue lines indicate the presence of allergens in the lower mainland, essentially, and then orange for the interior of BC. So our tree pollen season has already started down here in the lower mainland, and when the snow melts and the trees start blooming closer to April, up north, then the tree pollens come out. And then in May, the grass pollens start to come out a little bit later up north. So there are weed pollens that you can be allergic to. The major one being ragweed, but we don't actually have ragweed in British Columbia. And so we don't see a lot of problems with ragweed pollen allergies here unless you've moved from somewhere else. And then again, the molds I've put on here, there are outdoor molds you can be allergic to. They're really present year round unless the ground is totally frozen. Again, I don't see a lot of actual problems with mold sensitization. So there's an entity called the priming effect. And the idea is that the amount of allergen you need to create allergic responses becomes less over time. And it's because of this buildup of mediators that is present in the nasal and respiratory mucosa that takes time to go away. So you can imagine if with constant exposure, there's just a buildup of these mediators and swelling and inflammation, you really don't need that much more to create an effect. And that's why some patients you'll see, even though grass pollen season is ending in August, September, they're still having a lot of symptoms. It's because of this priming effect. And this is the reason why we tend to treat more prophylactically and encourage treatment with preventers early on and through the whole season and not wait for the symptoms to appear because it can be hard to catch up. So there's a well-known association between allergic rhinitis and asthma. Over 80% of people with allergic asthma have also allergic rhinitis, and 40% of patients with allergic rhinitis also report having asthma. So allergic rhinitis is a risk factor for eventual development of asthma. And then there is some evidence that movement of inflammatory cells from allergic rhinitis patients down into the lower airway can perpetuate or make asthma worse. And this is known as the one airway hypothesis. So there's a lot of information around this hypothesis. It's not been fully delineated, and there is a little bit of controversy, but I'll just leave it at that. Okay, so I thought we'd start with a first case of a teenager who lives on a farm on Vancouver Island, and he comes to see you with sneezing, runny nose, nasal pruritus, and congestion. And so his symptoms are perennial all year round and get worse between March and August. He's having a lot of trouble sleeping, and he's having a really tough time with his farm work, especially in the spring. And this is really important for his family because this is how they make money. So any thoughts on what things he might be allergic to just based on the pattern of symptoms? Pollen? Which ones? Tree, grass, and perennial symptoms? Dust mite. Yeah, and if he's got pets living on a farm, those certainly could be a problem. So he's taking oral diphenhydramine at least 4 times a week, but it's making him super sleepy, which is additionally making his work hard and schoolwork. So he's got some mild asthma triggered by colds and cat exposure. He had some bad eczema when he was younger, but it's getting better. He takes only salbutamol as needed, and he's got a family history of atopy in his parents. No pets or smokers, so that makes cat and dog allergen less likely. So when we see him, he's got typical signs. He's got the allergic shiners, he has Denny Morgan lines, and when you look in his nose, that there on the right is his inferior turbinate, and it's boggy. So for a long time, I didn't know what boggy meant. It just means it's edematous and pale. And it does have a bluish discoloration there. And so that's pretty classic sign of chronic allergic rhinitis that's been untreated. So skin testing was done, and you were right. So he's positive to dust mite, tree, and a variety of grass pollens. And so this is it's a bit simple, but this is the algorithm we tend to use for management of allergic rhinitis. So we have 3 pillars of therapy. So one is environmental avoidance. It's obviously really hard to remove everything, but we do standard recommendations like try dust mite covers, vacuum your carpet, don't put stuffed animals on your bed. It's only going to get you so far, especially in terms of pollen season. You can't completely avoid it. And then medical management is next. So it's a bit like asthma, actually, for those of you who are familiar with it. We use a controller, and then we use a rescue therapy. So in allergic rhinitis, the controller is intranasal steroid, and then we use oral antihistamines as needed for breakthrough symptoms. And so this patient really hasn't even had a good trial of medical management because all he's doing is taking diphenhydramine as needed, and it's not working for him. And so these are, I'm happy to share the slides with you if you think they might be helpful, but I just put this on here for reference as a summary because I found this confusing myself when I was training. So we have a variety of over-the-counter antihistamines, and the generic and the trade names are listed there. These ones all come in pediatric formulations. They all have basically equivalent efficacy. So they're all, no one's better than the other. So it doesn't matter to me which one you use, but they are better than the first generation antihistamine, which is what diphenhydramine is. So one other thing on sedation. They are all supposed to be non-sedating, but hold that thought. At higher doses, they can all be sedating with the exception of fexofenadine at the bottom. So if somebody is having trouble with sedation on higher doses of the antihistamines, you can try that one.
The prescription reaction, 20 milligrams is covered, right? So
yes, so that's a trick that we sometimes will use. So you can get prescription cetirizine in 20 milligram tablets only, but then families can have it covered. And so then we'll recommend on the prescription half tablet once daily. Yeah, and then I give a 6-month supply. But the other trick that I've found over time is that Costco in the US sells generic cetirizine for a fraction of what you can buy it here. You can probably get 200 tablets for $20. It's super cheap there. So I will send families down there if they're already going.
is rupatadine one that
So we now have prescription non-sedating antihistamines, and there are 2. So rupatadine and belastine. Rupatadine is the only one that goes down to 2 years of age. It comes in a liquid form, and and belastine is 12 and up. They are equal efficacy in terms of the non-inferiority trials with the other antihistamines, so they're no better, no worse. And I will sometimes use this as an option too for families who don't believe that normal antihistamines are working, because these are prescription and they're a little bit special, or families who have drug coverage to save money. And then we have a whole host of intranasal corticosteroid sprays that you can use. Only the fluticasone furoate and the mometasone go down to 2 years of age. But again, they're all equal efficacy. I would say that the fluticasone one has a finer spray. So I tend to save that for my back pocket drug in case the patients are not tolerating the other sprays, because it tends to be quite gentle. Okay, so for this patient, typically what we would do is say initiate a controller therapy. Try the nasal spray and treat breakthrough symptoms. Don't use the diphenhydramine, use something better, use something that's 2nd generation non-sedating, because it'll work longer and it won't make you sleepy. And then come back in 3 months and we'll see how you're doing. So he comes back. and he does a bit better with the nasal spray, but he's still using a lot of antihistamines. And in my practice, if you're using antihistamines 3 or more times a week, I consider that not controlled. And then he started having nosebleeds despite appropriate techniques. So he's not very happy. And his family is asking for some other options. And really what they don't want to see is him using medications year after year as a Band-Aid, essentially, because these medications don't make you less allergic. So when we look at our algorithm, we could try leukotriene receptor antagonist next. This particular family didn't want to try it. I found that there's maybe about a 50-50 chance that it's going to work for patients, and they didn't want to try that. So then we start talking about allergen immunotherapy. So what is immunotherapy? The idea is that we give small amounts of what you're allergic to the body repeatedly over time, and eventually your body develops immune tolerance to it, and it modifies the natural history of your disease and hopefully makes it go away so that when your body sees the allergen, it doesn't react to it. And so it works, it relieves symptoms, and it may prevent new sensitization in asthma, and I'll get to the asthma bit in a while. So I won't bore you with all the complexities of the immunology, but the idea is with this constant exposure, we get the generation of regulatory T cells, and they produce inhibitory cytokines. So they act at different parts of the pro-allergic inflammatory airways, and it causes decrease in cytokines. So IL-3, 4, and 5 are really responsible for allergic cascade. So it stops those from being produced. It stops the B cells from producing IgE-mediated antibodies, and therefore the mast cells don't degranulate, and you get decreased symptoms when you see the allergen. And then there's this increase in IgG4 levels, which we use as a marker of tolerance. And then we can expect prolonged benefit after 3 to 5 years of therapy. So it's indicated for anyone who has a relevant allergen. So that means you have to have a positive allergy test, but not just that, you need to have symptoms to go with it. So we see a lot of patients who've gone and had this smattering of allergy tests done, and then they're allergic to 30 different things. And really, they're just allergic to the cat, because that's the only one that matters. So it's really important to get a history and figure out what's really clinically important. So it's indicated in patients where we've tried medical management and it's just not working. The effect is too partial, or patients who don't want long-term medication therapy. Some patients just do not tolerate the nasal sprays no matter what we do. And actually in pediatrics, some of them flat out refuse it. So if it's not going in, it's not doing its job. Right now in Canada, we have approval for subcutaneous and sublingual immunotherapy. And because this patient has multiple allergens, we would have to go through the route of subcutaneous immunotherapy. So it's actually really old. We've been using it for over 100 years. Obviously, it hasn't been studied extensively for 100 years. But actually, because it's been used for so long, it's not as the studies have not gone through as rigorous of trials that we would actually like. So over time, people have just come to accept that it works. And there are many studies, but if you look closely, they're not actually as great as we would like them to be. I'll be honest about that. So it's a major time commitment. So we deliver the allergen through injections subcutaneously, and the buildup is a pain. So weekly shots for 5 to 6 months if all goes well. So if you're having major reactions, we have to scale back, we have to hold the dose, and that can take even longer. And then once you reach maintenance, it's 1 shot a month for 3 to 5 years. So you can do them pre and co-seasonal, but those have really sort of fallen out of favor because they haven't really been able to demonstrate long-term efficacy over time. So most patients will do them like on a year-round basis for 3 to 5 years. Although some of my colleagues are still doing pre and co-seasonal shots. The risks. There are a lot of local reactions. Most patients will have at least some, and this is to be expected, right? We're stimulating the immune system with something we know you're allergic to. Systemic reactions will occur in about 5%, life-threat or anaphylaxis in about 1%, and there is a risk of death. In the 90s, it was we would say 1 in 2.5 million injections, but I think the recognition of anaphylaxis and the management of it has improved over time. So there really have been no deaths in at least the last 3 to 6 years that I'm aware of. But it's not without its risks. So there is evidence in the literature for efficacy with the allergens listed there. These are most of the ones that are relevant to us anyways, but note that there is no study demonstrating dog allergy. And that is one question I get far too often. So families who really, really, really want dog and want immunotherapy, and it's really hard to justify doing that to a small child when there's no really great evidence for it. But there is evidence of improved symptom scores, decreased medication use, and improved quality of life. Most of these trials have been done with single allergens, and these days we will often mix allergens. There's a science to doing that. You can't mix all of them together, and some can't be mixed with others. But that is something I wish we had a bit better evidence on with multi-allergen subcutaneous immunotherapy. When we look specifically at pediatric studies, there's a good study from 2007. It was from Europe. Most of our studies are from Europe. There were 205 patients aged 6 to 14, and they were randomized to either a control group, open control group, or subcutaneous immunotherapy with the grass or birch pollen. And they got 3 years of immunotherapy, and then they were followed up at 5 and 10 years after immunotherapy stopped. So I'll just orient you quickly to this slide. So basically with the visual analog score, they're looking at symptom scores. And then we have rhinitis and conjunctivitis symptoms. And so after immunotherapy was done at the 3-year mark, they were assessed at 5 years and 10 years. And you can see even at 10 years, there's prolonged benefit, compared to the control group, which is really good. Beyond 10 years, we don't know how long it's going to last for. For some patients, the symptoms may come back at 10 years. For some, it's 20. And then in this study, it really got everyone excited. So they looked at the percentage of patients with asthma, and there was a significant decrease at the 10-year follow-up. You can see the numbers aren't very high, but at that time we thought, well, maybe subcutaneous immunotherapy can actually prevent asthma. But there hasn't been another study since that has been able to document that. And because it was just the percentage of patients with asthma, it may very well have been that a lot of these patients just outgrew it over time. There are some contraindications. So if you're on a beta blocker, we don't like to start immunotherapy because of the risk of anaphylaxis. If you have anaphylaxis and you're on a beta blocker, you're probably less likely to respond well to epinephrine. And because it is a therapy for quality of life measures, we tend to weigh the risks and benefits and prefer not to use it in those patients. The exception would be for venom immunotherapy, where you're definitely at risk for a life-threatening reaction if you get stung. Patients who have uncontrolled or severe asthma are not good patients to start on immunotherapy, and anyone with significant comorbid cardiovascular or respiratory disease are not good candidates. So it's not well studied in children under 6. We prefer not to use it in pregnant patients, although it is possible. Elderly patients have mostly outgrown allergens in the environment, but in some cases they do persist, and it can be done in the elderly. And then in malignancy, immunodeficiency, and autoimmune diseases, we prefer not to start it because if there's already something wrong with your immune system, it may not be a good idea to stimulate it. But that's not well studied either. And I mean, if you have a malignancy, I think you probably have more important problems to deal with than allergic rhinitis. So for referrals, when you're thinking about these patients, anyone can have subcutaneous immunotherapy. You don't have to just be sensitized to one or a few allergens. But you really should have a good trial of medication therapy because it really is much easier than getting a bunch of shots all the time. The asthma needs to be well controlled before we will even consider it. And then really the limiting factor in pediatrics is the injection. So they need to not be afraid of them, actually want to have them. And the family needs to be reliable in attending appointments. So if you're missing shots all the time, that puts you at risk for anaphylaxis when we give you your injections. And we've had to discontinue shots on a few patients because of inability to attend appointments regularly. So we'll move on to a second case, which makes me happier. So this is an 8-year-old. She lives in Coquitlam. She has the typical symptoms of allergic rhinitis and conjunctivitis, but this time her symptoms are only in the summer months, and the family is very clear about this. She is having a lot of difficulty with sleep because of the congestion. She's sleepy during the day, which isn't horrible in the summer, but it does affect her at the tail end of the school year. And her symptoms are worse every time she walks by a lawn with cut grass. And then when she's playing in the grass, she gets hives on her skin. And she's already tried taking the antihistamines all season long, and the effect is only partial. And she's really sad because she wants to play outside. And somebody tried a nasal steroid, but she doesn't want it, and parents do not think they can get it into her. So she's also a mild asthmatic. She is controlled with ciclosinide, and she also has atopic family history, so she's kind of the perfect patient. And then when you see her, she has evidence of chemosis, which is essentially edema and allergic inflammation of the conjunctiva. Pale boggy nasal turbinate, and I don't think it really shows up super well, but that is a transverse nasal crease from doing this all the time. So her nose is really itchy, and then they get this little line. And so you could probably guess what she's allergic to: grass. Okay. And so this family, mostly I just did not want this to be the focus of my talk, declined leukotriene receptor antagonists. And actually, now that we have an alternate option for immunotherapy, I actually don't use the leukotriene and the Montelukast very often at all. In the last few years, we've gotten sublingual immunotherapy approved through Health Canada. And it's really great for the pediatric patients. So we give it once daily. First dose is at the allergist's office, and then all the other doses can be given at home. It melts under the tongue within 30 seconds to 1 minute. And it's pre and co-season. Okay, so we have 3 products available in Canada, 2 for grass pollen, 1 for ragweed, and most recently dust mite. The only one that's really relevant for us in British Columbia for pediatrics is the grass pollen immunotherapy. Both ragweed and dust mite are 18 and up as indications from Health Canada. And ragweed we don't have out here. So really it's the grass pollen sublingual immunotherapy we've been prescribing. I'm hoping at some point the dust mite companies come through with pediatric data. I think it has to be North American as opposed to European in order for the FDA and Health Canada to approve it, but I hope it will come at some point because that would be great. And so the idea is the same. We deliver the antigen to the dendritic cells under the tongue, and they bring the antigen to the lymph nodes, and we induce T regulatory cells. So contraindications, again, we prefer not to use them on patients with beta blockers, which is not the majority of our patients anyways, patients with uncontrolled severe asthma. And we don't like to use it in patients who have oral lesions or eosinophilic esophagitis because it can promote inflammation. So because grass pollen sublingual immunotherapy is what we are using mostly here in BC, I just thought I would go into it in a little bit more detail. So we have 2 products, Oral Air and Grass Tech. Oral Air has 5 grass pollens in it, and Grass Tech only has Timothy grass. They are all highly cross-reactive, so both of them are considered efficacious. Oral Air is 6 and up, Grass Tech 5 years and up. And both of them are dosed pre-seasonal and co-seasonal. So we start them 3 to 4 months before the grass pollen season starts. Down here in the Lower Mainland, we start January, February, and then we continue through the grass pollen season. So in other parts of the world, it would really be a 6-month course of therapy. And here I'm mostly using 6 months, but some families have found some rebound symptoms when we stop at the 6-month mark, which is really June, July, because we're still right in the middle of grass pollen. So I've done 8 months for some families. For Oral Air, there's a short escalation phase, just 3 days, 100 IR the first day, 200 the second, and then day 3 and beyond 300. For Grass Tech, it's just the same dose, starting with day 1. So adverse effects are common but very mild. So a third of patients will have localized oral itching or discomfort, and most of that goes away within days, 2 weeks of therapy. Some throat irritation is possible, and anaphylaxis is really rare. So it says less than 1% on the slide, but I think it's really less than 0.5%. It's really low. It's not cheap. So last I checked, it was about $3.80 per tablet, which amounts to just over $600 for 6 months of therapy. Most patients with extended health benefits will have at least partial coverage. So it looks like most families are paying about 20%. But this really does leave the patients who don't have extended health benefits at a disadvantage. It works. So for the 5 grass pollen slit, what they've done here is 3 years of pre and co-seasonal therapy. So 3 years in a row, they'd start in January, February, stop in June, July. And then what they did was they stopped after year 3 and assessed them at the 4th and 5th years despite not having treatment. And they repeated measures of daily combined symptom and medication use scores. And you can see the first year, even in the first year, there was significant benefit, but it improves on the 2nd and 3rd years of therapy. And even when you take the therapy away for the 4th and 5th years, there's prolonged benefit. We don't have studies published for anything beyond that, so we don't really know what happens in the 6th or 7th year. And it's the same for the Timothy grass pollen slit. So very similar, 3 years of pre and co-seasonal therapy, and then the subsequent 2 years prolonged effect. So one question we're always interested in is whether the sublingual immunotherapy can improve or prevent asthma, because that would be great. So not only could it make your symptoms get better, but if it could prevent another disease, that would be amazing. Unfortunately, most studies were really focused on allergic rhinitis and conjunctivitis symptoms. So they're able to say that it's safe to use in patients with mild to moderate asthma, but not a lot of them actually look at the effect of sublingual immunotherapy on asthma itself. There was a rather disappointing Cochrane review actually in 2015. They looked at 34 randomized controlled trials with both adults and children and weren't really able to come to any conclusions at all. So if you read many Cochrane reviews, a lot of them will say something like that, right? We looked at all these studies, there was a lot of heterogeneity, and none of them really compared the same thing, so it's really hard for us to provide any firm conclusions. But hot off the presses, just earlier this year, there was the GAP trial, which was published. And this study looked particularly to see whether the grass pollen sublingual immunotherapy tablet could prevent asthma. And they looked at a lot of children. So 812 children, randomized double-blind placebo-controlled trial, 3 years of sublingual immunotherapy and 2 years of follow-up. So as expected, we see a decrease in asthma symptoms. So these patients did have less need for medication, less symptoms, and improved spirometry. And actually the effect, it looks like it's become more prominent over time. So that's good. So patients who have asthma and grass pollen allergy who receive sublingual immunotherapy have reduction in asthma symptoms. But their primary endpoint was to see whether they could prevent asthma. So they looked at the time to onset of asthma and the patients who didn't already have it. And between the placebo and the tablet, the intervention groups, there was no difference. So this is a big trial, and they weren't able to show that immunotherapy in children for grass pollen prevents asthma. And it may be that a bunch of these kids already had asthma, and then, you know, by the time you have allergic rhinitis, we have a decreasing incidence of asthma. So that may be part of it. But nonetheless, we can't use it to prevent asthma right now. So most guidelines aren't recommending sublingual immunotherapy as management for asthma in children or adults, and all the guidelines are listed there. But I do think there's a role for adjunctive management. So if you have someone that's got good control in their asthma and they only have a grass pollen allergy, it's reasonable to try the sublingual immunotherapy and might even get them off of the asthma controller medications. So in this case, the patient elects to start the grass pollen immunotherapy. He's completed 3 seasons, and she did so well. Stopped all medications for allergic rhinitis, and now they don't want to stop. So now they're on their 5th year, even though I said they could try and stop after the 3rd year, and they'll probably just continue to use it until they don't have drug coverage. Okay, so grass pollen slit is really most relevant for our population, and so think about it when you see these patients, because it really has made a remarkable improvement in a lot of patients I see. So if you suspect that it's just grass pollen only, and I would be happy to consider it. Some patients come and they only have symptoms in the summer, and yet they have a positive skin test for dust mite or cat or something like that. But I'll still try it if they're not having symptoms year round. And we do, so just keep in mind that we do need to start it before grass pollen season starts. So we can't really accept a referral in June to start grass pollen slit. But since our waiting list is so long, they probably won't see us until January anyways. But just keep that in mind. And the asthma needs to be well controlled. And so finally, when we're comparing the 2 forms of immunotherapy, it's a little bit tricky because they are really different, right? And so subcutaneous immunotherapy is, if you balance out all the studies, the efficacy is probably better than sublingual immunotherapies. But sublingual immunotherapy is really convenient. It's much safer. And then we don't have the added stress of needles in the children. So when you look at the adult literature, the balance is actually totally balanced because they feel that both have enough risks and benefits that they weigh each other out. I think in pediatrics, the sublingual immunotherapy actually, I prefer it if I can use it in the right patient. There's only one head-to-head randomized trial in pediatrics looking at the 2, and really they did show about equal efficacy, but only a significant decrease in the asthma symptom scores for a subcutaneous group. Okay, so last case, requested by Kelly. So we have a 10-year-old male who has 2-year history of suspected symptoms of allergic rhinitis and conjunctivitis to his pet cat, and also in the spring months. So he's doing well with oral antihistamines, but his parents really don't want him to take medications. They want him to have natural therapy. So he gets seen by a naturopath, and naturopath diagnoses him with allergy to cat and weed pollens. And now a parent comes to you and says, my child is receiving immunotherapy. So what is going on? So have any of you seen a patient like this? Kelly? Did you know what they were receiving? Did you ask? Oh, okay. Anyone else?
I don't know if they were on either though.
No.
They couldn't tell me the name of it.
Okay. Did they tell you what kind of immunotherapy it was?
Yeah.
Is it similar to the vaccine?
Yes. So actually, when Kelly asked me this, I didn't know that naturopaths were doing immunotherapy either. And I said, okay, well, since she's asked, I need to know. And then I went and booked myself. I went undercover as a homemaker to a naturopath's office. It actually wasn't that easy. So I did phone around to multiple offices and asked for a naturopath who specialized in immunotherapy. So to their credit, many offices declined and said you have to go see an MD for that. But I did find one downtown, and I went to see her. So she did skin prick testing, just like we would, using similar extracts from a company called Western Allergy, who they supply extracts to allergists and also naturopaths, which is a huge sore point for us. So she had all that stuff. And then I'm not sure about the equipment. So our skin testing supplies, we're supposed to be using these standardized tools. And we use these blue duo tips in our clinic. But she told me that day that she had run out of her skin testing equipment. So I was going to get acupuncture needles, which were definitely not epicutaneous tests. So they were deep, they were subcutaneous. And I was not concerned for my safety, but perhaps of other patients. And it was quite painful. So she did my skin testing with acupuncture needles. And then she charged me for it. So it was $70 in addition to the $220 I had to pay just to see her. And this is really expensive because we just charge MSP for it, and we don't make patients pay out of pocket, and that really got me. And then they give you this lovely pamphlet on sublingual immunotherapy, but this is not a tablet. And as Sharon mentioned here, it's a drop. And so I don't know if you can read all that. You're not really meant to read it, but basically it tells you that it's better than needles and it's very effective, and your doctor will give it to you, which is the naturopath. And then this is the other side. It says it's proven in many studies, and yet why aren't we using it? So I went to go look for evidence for efficacy for the sublingual drops, and it's not great. So these drops are used pretty widely in Europe, but when you look at the data for pediatrics, there's no really consistent data to recommend its use. So all the data shows that it may have some short-term benefit, but no long-term benefit in allergic patients. So the long-term studies were done in dust mite for patients, and then you can see here by this chart that a lot of what they looked at was either not looked at or there was no improvement. So it's really not consistent. And then for pollens, they were only able to demonstrate short-term efficacy. And it's interesting because these studies were done in Europe. So when I look at the European guidelines for allergic rhinitis, it says there is strong efficacy data for use of drops in pediatrics. But when you look at these studies, like look at the numbers, it's 38 patients and 60 patients. And in medicine, we don't consider those to be large enough numbers really to be very convincing. And so when I went to the naturopath, she recommended a duration of therapy of 3 to 5 years, year round. And I asked about side effects, and she said they're really uncommon. You might get slight itching or irritation in the mouth, but they're really, really rare, which is a bit concerning to me because you're supposed to have some side effects in at least 30% of patients who are receiving the grass pollen slit tablets. And we need to know that you're stimulating the immune system. So most patients on immunotherapy of some kind will report symptoms. And so the fact that it's very rare to have side effects makes me worry that the concentration of these extracts is actually really, really low and possibly ineffective. So for the initial vial is $95, and then subsequent vials are $105. And so one vial equals 2 months of therapy, so that's $630 per year, which somebody would be paying. You would think out of pocket, but you can submit it through Extended Health through specific DIN numbers, which is really unfortunate because that means that somebody else is paying for it and families don't realize that this is maybe not okay. Because if you can think about it from a layperson's point of view, why would anybody cover this if they didn't think it was effective? So it's unfortunate. Okay, so when I see patients seeking alternative medicine a lot, and I'm sure you do as well. So I have them grouped into a few categories in my mind. And one is this one, the parent that just got led astray. So they didn't mean any harm. They just, they had family or friends who were into alternative medicine who recommended these things and they just did it. Or they were waiting to see one of us and the wait list was just too long. So they got desperate for answers and went to the naturopath who got them in within 2 weeks. And then there's the kids that they're already getting a bunch of treatments. So there's the anti-medication parent. And then there's a parent who believes in Western medicine, but just wants alternative medicine, well, a complementary therapy. So they want to add on. And then in these particular scenarios in allergy clinic, there's the patients who might go to the naturopath. So they're just sort of asking you, what do you think? There's a patient who's already getting slit drops. And then there's always the parent who thinks the symptoms are due to food allergy. No matter what the symptoms are, they think it's a food allergy. And so I'm curious to know at this point in the presentation what your approach is and what you would say to these families. And it doesn't have to be specifically about immunotherapy, but what your methods are for discussing this with families. Because that was the one thing Kelly had asked about. She said, I need something better than just to tell the families that this is not appropriate. But then what do we say? Are there still outside sites listening in? Yep. Penticton, I think I saw. Okay, I won't pick on you and make anyone uncomfortable because you're not residents.
I'll say that medicine and naturopaths have some things in common and some things differently. Medicine tries to focus a lot on science, and naturopaths use different methods as well. And so as a medical doctor, I will offer you treatments that are based in science. You will have to ask the naturopath what their treatments are based on.
And do you find that families respond well to that?
They do, yeah.
And so what percentage of those families, I'm curious, go to the naturopath after that? Do you know? I guess, yeah, okay.
But my clinic ones, some of them will think, at least they don't tell me they go anyways.
That's really helpful. So yeah, that's one approach, is to just be really honest. We're practicing science here, and the naturopathic practice is different. So some of my colleagues will say, I don't know anything about that practice, and therefore I recommend what I know, which is evidence-based. Any other thoughts?
One of the things I generally talk to parents about in regard to food allergies is generally you don't have to look for them, they will find you. And that it's an obvious reaction and you're not going to get much from testing. And with eczema, for example, I'll say, it used to be thought that diet had no relation whatsoever to eczema, and that's changed. But it really is so obvious when it happens. Every time he eats strawberries, he breaks out in eczema, and that you can't do, it's really fruitless to do random fishing for answers.
So strawberries is a good example, because I think one approach that really has helped me a lot is to acknowledge that some foods can make eczema worse. So before I completed my fellowship, I would just say, no, it's not, foods don't cause eczema, they don't make eczema worse. But actually some of them do, like strawberries, and it's because of contact irritation. And then when I add that in, they're like, oh, okay. So other things like yogurt and citrus fruits, when they touch your skin and it's broken, that can make eczema worse. And that is a reaction, but it's not an allergy. And so that does help. So I saw a hand, James.
Well, a lot of these parents have sought IgG allergy testing, which is a morass.
Yep. So now we're sort of getting into food allergy, but that's okay. So IgG testing, the great thing about IgG testing is there's a position statement put out by the Canadian Society of Allergy and Clinical Immunology that I just print out and give to families, and explains what IgG testing is, and that it's not appropriate for diagnosing IgE allergy. And actually, I think I had a slide earlier indicating that IgG levels increase with immunotherapy, and they are a marker of tolerance. And so obviously it makes sense when your dairy eating child goes to a naturopath and the IgG to dairy is high. It's because you're eating a lot of it and it's okay. And I don't say it in that manner, but it helps to explain that to families. So this is my approach. So I prefer to educate myself on what families are being told. I used to sort of shy away from it and then just say, like, I'm not sure, I don't know what it is. But then I realized that it just made me look kind of stupid. And families would turn around and they say, well, you're just unaware, you just don't know, and I know more than you. And that was really frustrating. So then I now try and figure out exactly what is going on, and it does take time. So what's the testing that's being done? And this, I could do a whole other talk on like VIGA testing and IgG testing and iridology that is being done, but you just understand what they're meant to be doing with the testing and what treatments are actually being offered. Then I use evidence to debunk. So I look at where the confusion arises. So is it the physiologic reasoning? And then I do my best to explain physiology in simple terms. Is it the test that's done that's incorrect? There's actually a really great website, and I'll forward it to you, that actually has a whole section on unproven tests for diagnosing food allergy. And there are randomized trials done for things like Vega testing and IgG testing that indicate they're not good tests. And so when you can debunk it with science, that's really helpful, because it's not just me giving you an opinion. And then treatments. So when there's treatments like slit drops or whatever, I always go back to my PICO questions and do a lit search. And then I know for sure what I know. I discuss any risks associated with alternative medicine. Some patients have come to me with a peanut allergy, saying their alternative care provider gave them a vial of peanut oil and they're carrying it around in their sock, and it's supposed to make the peanut allergy go away. And that really worries me, because that's a false sense of security, and that's potentially dangerous. So things like that I'll talk about. And then I offer something that is evidence-based. So if your child is on these slit drops, I don't think there's really strong evidence to use this. And so I would recommend this instead. So at least there's something else that you can offer. And I usually discuss guidelines so that they know that lots of people are doing this method of therapy. And if all else fails, and this is my last step, at least try to explain to them what an allergy is and what's not an allergy. So an allergy is when you have a risk of anaphylaxis or environmental allergy. Like, it's pretty clear. You get the symptoms right away, all the time. It's reproducible. Everything else is a lifestyle choice. And then they can get that. So I just need them to know that their child is not in danger from whatever it is they're worried about. And if you want to move houses because you think there is mold infestation, then that is not an allergy problem. I don't see the pediatrician here who referred a child for that. But yeah, I had a patient who mom was sure the child had a mold allergy. And it was actually quite sad, because she had taken her child from their home, their family home, separated the family to live in a different place, and thought it was a mold allergy. And so for that patient, I did skin testing. It was negative, and that was the conversation I had with her. So some things that I don't find helpful, and some I have learned the hard way, and some I've learned from watching my colleagues, not here, perhaps maybe in other parts of the world. So being dismissive, and sometimes being dismissive from us is just a bit of a protective mechanism. And it's not because we really don't care. It's because maybe we don't know enough about what is going on, or we're really busy, or there's just something else going on. But I have found that tends to sort of fan the fire. So I do try and take the time to sit down and address it face to face. Belittling the alternative care provider. So this sounds obvious, like why would you do that? But I have seen many of my colleagues, not here, do that, and they would look them in the eye and say, I have this much education in allergy and immunology, and I'm the expert, and by the time I'm done with you, I'm going to tell you why the naturopath method is crap. And that's just not going to do anybody any favors, because people will feel really offended by that, especially if they truly believe in that method of therapy. And so using strong language also I find is not very helpful. So when we're categorical about things, that seems to get people's back up. So I tend to use really soft language, and I would say things like, most of the time it's not due to allergy, or in most cases this is what happens. But I never really say this is for sure what it is, because in medicine nothing's absolute, right? And so I never tell people that it's impossible that their child eczema is getting worse from the wheat. I think that there is a less than 1% chance of that, but I don't use that language because it just makes people upset. So talking about the cost of naturopathic treatments, it makes me really mad when someone's spending $630 a year on something that I don't think works. But families, they'll just say, oh, it's for my child. I don't care how much it costs. And so that has never worked for me, ever. They feel like, I think that when they're charged for something, it seems that it works better, or I don't know, it's something psychological. And then I've seen a few families where there's been hesitation to refer to us, and I suspect some of this is waitlist related. And then as pediatricians and even family doctors, they say, well, it's allergic rhinitis. I'll just treat it with antihistamines, which you should do. But then there are patients who don't respond well, and we do have a role. And sometimes when they don't feel that they have access to one of us, they go to an alternative care provider who does provide them with advice, and that can really lead them down the wrong path. And we do have a lot of good pediatric allergists now in the community who you don't need to wait a year for. And arguing. So if you get to the point where you're feeling like you're getting in an argument, I would just stop the conversation, because it won't end. And so wherever you are in this argument, I go back to method number 5. And so if they're not hearing anything I've said, I just fall back on this is an allergy. I don't think it's an allergy. Everything else is your decision, unless I think that the patient is at risk of danger. So unless your child is a baby who's eating 1 or 2 foods only and is failing to thrive, I'm willing to work with the family, and I think that helps as well. So see them in follow-up, try and gain some rapport over time. And the other thing I like to say is your child's body changes a lot over time. So maybe in 6 months it's worth a try again, because a lot of things will be different. And that actually, I think, does work. So last slide. Allergic rhinitis and conjunctivitis really does affect quality of life of many children. The mainstay of therapy for pediatrics is the intranasal steroids plus antihistamine as needed. Subcutaneous immunotherapy is really best for older patients who can tolerate the needles, and patients who have multiple sensitizations, because we can mix them. Grass pollen sublingual immunotherapy has really good evidence for symptom management in both rhinitis and asthma, but no good evidence for asthma prevention. And I think the key to managing families seeing alternative healthcare providers is to educate yourself and what others are doing, and keep up to date with the scientific literature, so that it really does appear that you've considered all aspects, and then it really looks like you've really kept the interests of the patient in mind, when you really know about all the things that are going on. So I just like to acknowledge Stephanie from the BC Pediatric Society and Kim from Steller-Jean's Greer for putting this together tonight. And I hope that you've learned something from it. And if you have questions, I will gladly take them. Maybe I could start with the outside sites. I can't actually see very well. Penticton?
I have a question. Can you hear me?
Jane here?
Yeah, it's Jane. I just have a question.
It takes so long to see you guys, so if you do serum-specific IgE, would that be good enough to start the oral immunotherapy on our own? I've never done this, but...
So as far as I'm aware, sublingual immunotherapy needs to be prescribed by an allergist. But I think it would be reasonable, although it's not an ideal test specific IgE, you can start with that, and along with appropriate history, you can start managing it with medication therapy, and then if that's not working, or you can refer to us and then start medication management, and then by the time...
And then I've been told that dust, so there's dust mites now too, but
yeah,
I've been told that dust mite settles out pretty quickly, and then you just have to sort of start with the bed and work your way out, and maybe we don't need to vacuum the drapes and all that kind of stuff.
So the problem with dust mites is they're everywhere. Yeah. Really, so we can get covers for the pillow and the mattress with a really tight weave that prevents the aerosolization of the fecal material. But it's still in your duvet. It's still in the drop sheet you're using. And it's still in the stuffed animals that are all over these kids'
But
beds.
still within the bed then, so.
Yeah. So it's the bed that's the most important because we sleep in it.
Yeah.
There are studies showing that if you can aggressively use the dust mite covers, wash your linens in hot water once a week, vacuum, et cetera, you can minimize the amount of dust mite exposure. And it does work for some patients, but it's not a panacea for sure. What's the other side there? I can't.
Some were for making violent, and they said 9 were Korea.
Just feel free to shout out if you've got anything because I can't see very well.
Are they working on oral immunotherapy for cat?
For cat.
Hopeful.
Oral immunotherapy, so sublingual immunotherapy. I don't know. I did see a study recently on a tree pollen sublingual immunotherapy that was promising. But to be honest, I don't know about cat. I'm sure they're using drops in Europe. Are you aware of anything, Kim?
Drops in Europe for sure, and drops in Europe are very different than what is available here in North America. Drops in Europe are actually studied, dose finding studies, the rest of it, so there is a large efficacy in Europe. But as far as I know, from a tablet format, cat, no. Birch is going to probably be the next one out.
So there's a question here from Jane Pegg, and the question was about long-acting antihistamines. I always thought you had to take them daily for effectiveness given the long half-life rather than taking them PRN. So if you're already receiving a controller therapy, which in the world of allergic rhinitis is a nasal spray with a steroid in it, you don't need the long-acting antihistamine on a daily basis. So we just use it as a rescue. Does that answer your question? You could use it every day, but patients will find that it doesn't target the late phase reactions very well. So even though the itching and the runny nose is getting better, they're still really congested. And so in order to combat the congestion, you really need the steroid.
Is there an age or like a time into symptoms that is more effective for using the immunotherapy? So like if you've had symptoms for 10 years, is it worse than if you've had symptoms for 1 year in terms of efficacy?
I don't believe there are any studies looking at that particularly. It might be a bit hard to do those studies. So I would say I don't know. I don't think so. So I've seen patients who've had these symptoms for 8 years respond, as well as a patient who's had it only for a couple of years. Where it might make a difference is potentially, and I didn't really get to talk about this, was preventing new sensitization. So you have a grass pollen allergy and we give the grass pollen immunotherapy. Could it prevent dust mite allergy? And I didn't really get into it because I don't feel like the data is really that compelling. But there is some suggestion from studies that that may work. And in that case, the younger children would have an advantage. Okay, it's really hot up here. So if there's nothing else, maybe if you want, I can pass on my slides and they can be distributed. And you can email me if you have any questions. Let me just put my email here for, oh, it's gone already. Oh, sure, I'll put it on the slides. Or you can, everybody knows how to get hold of me anyways, I think. Oh, here we are. Okay, this is more for the outside sites. There.
We're enjoying your desktop.
Oh no, what's on there?
It looks very tidy. Yeah, it looks
Oh.
like your kids in.
This is tidy? It's okay. I don't think my husband would find it tidy. Okay. Well, thank you very much for your attention.
Thank you.